change is very hard. I remember sitting down with one of my patients, and she came to me that day and said, "Hey doc, I've decided to quit smoking." And I was like, "You did? I mean, tell me about this. What's this about?" And then she went into this whole story about how she was, she has been coming to the doctor and she hadn't always seen me, but every time she came in, she was getting like this message that smoking is bad, and she's like, "It's got to me. I need to quit." So when you're seeing changes like that across the organization, clearly things are going well.
We were looking for ways to improve health in a broad sense across the community, and tobacco certainly appealed to us in that sense. It's the leading cause of premature death and disability in almost any community, and it's also one for which we have very clear evidence-based strategies. Denver Health takes care of a fairly high tobacco use population. When we started this, it was about the adult smoking use was about 27% of the population. That's substantially higher than the population as a whole. In Denver, the population as a whole, it's about 17% at that time of adults smoked.
A population is often thought of as statistics, as numbers, but in reality it's people.
How can you have a population health impact from an individual intervention? And I think it's a challenge. You can do so if you get appropriate reach and fidelity and consistency, and if you couple clinical interventions with community interventions. I think that's how you can have a population reach effect. Our initial steps were just within our own house as Denver Public Health. And we started to reach out to our partners in the big Denver Health system. So we're a department within Denver Health, and so it was really quite easy for us to reach out to the other parts of Denver Health because we work with them on a regular basis. We use the same electronic medical records. We can access all their data, they can see our data. So it was that much easier.
We had a mandate from some organizational leadership that we needed to apply some changes and get better at this.
So we took the ask, advice, refer approach to tobacco cessation because we know it's been proven or evidence-based in terms of its effect on tobacco cessation. Because one, it's important to find out if they're actual smokers or not, and then also number two, it's important to engage the patient regarding their smoking. And number three, give them a resource to help them with their cessation. It wasn't a hard sell to our organizations.
The incremental addition is relatively modest, but the idea was not that you would have a population health effect by doing it once, but you would have an effect if there's consistency. Again, if there's consistency in asking, advising, referring, there could be a population health effect. Remember that in almost any survey of tobacco users, 2/3 to 3/4 want to quit. So you're not, in most cases, trying to swim upstream. You're trying to support a person who already says, "I want to quit." We started to see a 1 percentage point per year decrease in adult smoking prevalence. And that might seem very small. It's not. That's more than twice the decrease that's seen in the general population in the United States. The adult smoking prevalence in our patient population has gone from 27% to 20%. And the importance of the feedback was, I think it just energized everybody to see this data and to say, we're having an impact. That providing this in a systematic, scripted way with clear messaging is working.
On a consistent basis, I go to different clinics and I see on their boards, we have boards up in clinics that kind of show them how they're doing. And on a consistent basis, I see the tobacco metric up there and see them being very excited about it, recognizing that they're making a change, not just on a random metric, which is sometimes tied to finances or tied to other things which we see as important. But let's be honest, when you get someone to quit smoking, it's the gold standard in public health interventions. We know it impacts their health. It impacts so many different components of their life.
keys to our success, I think, have been that we do it consistently, that hopefully any place you touch the big Denver health system, you get asked, you get advised in a clear way, and you get referred if you want help. And that we did that everywhere. This really has been incorporated into the quality improvement system, the safety and patient safety and quality system in a way that we don't need to provide ongoing support. The success we've had has clearly influenced how we're planning other initiatives. So in a number of areas. One is that we're working with the clinics around perinatal mental health, that is during pregnancy and after pregnancy. And we used many of the concepts that we developed and proved, identifying a clinic champion, working on quality improvement feedback loops, openness of data, transparency of data, feedback of lagging metrics. So all of those key components that came from tobacco cessation are parts of that effort, and it's having a lot of success.
I think often people think that population health is a boring enterprise. What we've realized in doing things like this is those components and those philosophical and the challenging ways that we think through these very complex problems really have a very real world outcome. I have seen my patients dramatically change through the intervention of this Ask, Advise, and Refer program over the past few years. And I can tell you that it's not one patient, it's hundreds of my patients, and it's thousands of our patients. That's been very exciting.